Welcome to all. This is Silvia for the Geneva Global Health Hub Steering Committee. Here we are at the first of this week's Global Health Policy Debates organized by the Geneva Global Health Hub in partnership with its members ahead of the Executive Board meetings starting on Monday. Please stay in touch until the end of the session to learn more about what's happening next week. I would imagine, the topic of today is a common but differentiated responsibility that is a crucial principle that have to be explored in its legal applicability to the pandemic treaty the IMB is discussing. This is a very relevant issue also for Geneva Global Health Hub itself, because it has taken on the challenge to be part of the IMB. And here the issue are two: is it feasible? And if so, in legal term, is it worth it? Is a broad debate, and we have all to learn from our distinguished panelists. And we are more in a listening mode today. So I guess most of you are familiar with the Geneva Global Health Hub. If you are not, please do consider joining us via website or following the link that will be shared during our meeting. The Geneva Global Health Hub is a growing network of more than 130 organizations from all over the world. So if you are a civil society entity meaningfully engaging in the global health arena, this is your place. So before giving the floor to Eolan and our distinguished panelists, some basic and simple ground rules. Please raise your hand to engage directly in person for asking questions. The chat is meant for comments and material, but please, the first option is to speak your question. And now it's with pleasure that I'll give the floor to Eolan. Let's start.
Great, thank you very much, Sylvia. Can you hear me okay?
Yes.
Great, so yeah, thank you, Sylvia, and thanks also to all the colleagues at the Geneva Global Health Hub who've been running such a great series of meetings this week in the lead up to the executive boards. So as you'll all seen, the focus of this discussion is going to be the principle of common but differentiated responsibility, or CBDR for short, and the potential for applying this principle in the field of global health, and in particular the field of pandemic prevention, preparedness and response. And this topic is especially timely now with the ongoing negotiations around the potential pandemic accord that are taking place at the WHO. So for those of you who have been following these discussions, you'll know that the principle of CBDR has become a very hot topic in the negotiations. Language referencing CBDR has been included in the most recent conceptual zero draft for the accord and has had strong support from several countries in the global south. However, at the same time, there has been pushback and caution about the use of CBDR in the accord by other stakeholders, led by WHO member states based mostly in the global north. So the latest draft for the accord is scheduled to be released on the 1st of February and then debated by member states later this month. So this is still very much a live topic. Will the principle of CBDR be included in this latest draft of the accord? Should the principle of CBDR be included in the accord and in pandemic preparedness efforts more generally? And then how can this principle be operationalized in the context of pandemics and global health? So for many of us working in the field of global health, the principle itself of common but differentiated responsibilities, which broadly speaking is the idea that while all states have an obligation to address climate change and the protection of the global environment, different countries have different capacities and different responsibilities this principle is not one that we may have been very familiar with until quite recently. And then for those of us who work in the field of climate change and environmental protection, the principle of CBDR and its practical implications will be much more familiar, going back at least to the UN Framework Convention on Climate Change in 1992. But the potential for using this principle outside of climate in the field of global health and of pandemic preparedness is one that we may be much less familiar and unclear about. So it was bearing all that in mind that this discussion has been organised, and this policy dialogue will support participants to become more familiar with the principle of common but differentiated responsibilities, and to explore and debate the use of CBDR in the field of international health law and the proposed pandemic accords. And to help guide and inform this discussion, we're very fortunate to have a very strong panel of experts to provide their experienced perspective. So our first panelist is Vicente Paulo Yu, and Mr. Yu works as an independent environmental and trade law expert and consultant for various UN agencies and NGOs, and is currently a senior legal advisor with the Third World Network, a visiting research fellow at the UN Research Institute for Social Development, and a founding partner of the Clean Energy Innovations Partnership, among other roles. His work also includes the provision of technical policy and legal advice to developing country governments on the right to development, development economics, international climate change policy, and South-South cooperation. Our second panelist is Matayangai Sirleaf, who is the Nathan Patz Professor of Law at the University of Maryland School of Law. Professor Sirleaf's work examines how seemingly neutral international laws further global inequities, and her commentary has been featured in leading law reviews and online fora. Professor Sirleaf serves as executive editor at Just Security, on the board of editors for the American Journal of International Law, and is also currently editing Race and National Security, a forthcoming volume with Oxford University Press in 2023. Also with us is Nirmalia Siam. Mr. Siam is the Senior Program Officer for the Health, Intellectual Property and Biodiversity Program at the South Centre. Mr. Siam has more than 10 years' experience on issues related to intellectual property rights and access to medicines, and he holds a bachelor's degree in law from the University of Calcutta and a master's degree in international law from Jawaharlal Nehru University in New Delhi. And last but not least, we have with us K.M. Gopakumar. Mr. Gopakumar is a senior research and legal advisor at the Third World Network, an independent, not-for-profit organization carrying out policy research and advocacy on issues around trade and development, with a focus on third world countries. His work at the Third World Network focuses on the global IP regime and its implications on development. And we're very fortunate to have with us Priti Patnaik to act as moderator for the presentations from this panel of experts, and to also lead us in the wider discussion and Q&A session in the second half of this meeting. Ms. Patnaik is the founding editor of the Geneva Health Files, which is a weekly investigative newsletter that tracks power and politics in global health. In her 20 years in journalism, she has reported on global health, international trade, finance and illicit financial flows, and she has worked as a reporter in Geneva, New York, and New Delhi. So we have a really great discussion to look forward to. So in the interest of time, I'm going to pass right over to Priti, and we can jump straight into the presentations and the discussion. So thank you once again to everyone for joining, and over to you, Priti.
Thanks so much, Yolan, and thank you for joining us, everyone. I'm very happy to be moderating this session and to learn from our panelists today. This is a very key and timely topic that will no doubt feature prominently in ongoing global health negotiations in Geneva. Just to explain the structure of the session, we'll begin with initial remarks from the panelists for about 40 minutes or so, and then we head into discussion, at the end of which we will have participation from the audience. Please raise your hands as we come to that. So we'll essentially hear from our panelists on CBDR and how it can be incorporated into international health law, and also how responsibility can be reoriented in the context of health emergencies. Is the principle customary international law? And what do obligations on cooperation look like? These are some of the themes we'll be hearing from our panelists. Before I turn to Vicente for the first round of remarks, just one housekeeping rule. I would request the panelists, if possible, to keep your camera on and for others to mute, and that will be helpful. Vicente, go ahead. Thanks so much.
Many thanks, Priti, and thank you to the organizers for inviting me to join this panel. It's something that I have, the issue actually is something that I have started following, and it's been quite interesting. Let me share my screen because I do have some PowerPoints that presentations that I would like to provide to sort of guide us in terms of the conversation. So can everyone see it?
Yes.
On the screen. Okay, thank you. So I've had the privilege of negotiating on behalf of developing countries in the climate negotiations over the past almost 15 years or so, as well as working with developing country governments in other multilateral arenas, including in the WTO, in the CBD, and in UNCTAD. And I think one of the most important policy considerations that developing country governments often raise over and over again when they start engaging in international treaty negotiations is this concept of equity. As being a key concept that has to be embedded in international negotiations. And I think this is very much clear, for example, in both the health regime and in the climate regime. So what I'll try to do in my presentation is focus on how we look at equity and what is the relationship of this equity idea with the concept of principle of common but shared responsibility and other similar principles we have in international law. So let me start off by sort of like linking both the health and climate regimes together, because when you look at, for example, the constitutional documents of the multilateral health regime and constitutional document of the multilateral climate regime, both of them have jumped off from a very, I would say, common approach. One is that there is a recognition that you have a global issue which is of common concern to humankind. So in the context of the WHO Constitution, for example, it essentially says that the highest level of health and the attainment of that highest level of health by all peoples is the objective of the WHO, and that all countries, all states have to work together to make sure that this is undertaken and achieved. And the same thing with the UNFCCC, the UN Framework Convention on Climate Change, where there's an acknowledgement that climate change is a common concern for everybody, that all countries have to work together, and that there's that objective that needs to be achieved. When you look at the equity concept in international law, it is something that I think harks back, more than 2,000 years, back to Aristotle, where essentially the idea in terms of international law and fairness and equity is that equals should be treated equally and unequals unequally. And when we apply this to the current international relationships that we have, I think it really goes down to what Yolan was saying earlier about developed and developing countries not being treated in the same way when it comes to having obligations, or when it comes to implementing those obligations, and when it comes to being provided with the enabling means to undertake those obligations. Because when we have an international treaty arrangement where everybody's treated equally, and we know that in underlying that equal treatment, for example, there are inequalities that would hamper the ability of some states, for example, to actually implement those obligations, then you would have this kind of situation where not all states will be able to, in fact, actually implement those obligations. And then you have, and then therefore equality, having formal equality within a treaty system actually negates that idea of equality because it actually exacerbates inequality. And therefore, I think the key thing here is to look at how can we make that treaty regime equitable. And this is what has been reflected in many parts of international law. For example, in international environmental law, we have this principle of common but differentiated responsibility. In international trade law, we have the principle of special and differential treatment. And even in international health law, for example, we have that recognition in the WHO's Framework Convention on Tobacco Control that recognizes that there is some kind of affirmative action, if you will, to provide support to developing countries so that they would be better able to implement the obligations that they're assuming under the treaty. So the idea of in international environmental law, in international trade law, and international health law with respect to equity is that there's an acknowledgement that there is a shared obligation to address a global commons issue, for example, but that shared obligation, that common obligation is not necessarily the same for all, because some states might have greater historic responsibility or greater capacity with respect to some issues. And then there might be some states that might have less in terms in terms of historical responsibility or in terms of the ability to actually implement the obligations that are being assumed. So let me walk one by one, quickly through some of these. So the idea of having some kind of differentiated common but differentiated responsibility approach or differentiated treatment approach in the context of a treaty system or a treaty regime is essentially to have three things. One is to make sure that we have substantive equity built in as a key element of the treaty. The idea of fairness within the treaty is going to be very important for its credibility and its legitimacy. Second is to build into the treaty aspects of international cooperation that would actually then go to the third point here, provide incentives for states to actually implement the obligations they're assuming under the treaty. And this has very long antecedents, this idea of common but differentiated responsibility or equity, if you will. For example, international, it goes all the way back to 1949 and 1982 in terms of the common heritage or common idea as being the framing narrative for then building a treaty regime that would then have some kind of differentiated approach between developed and developing countries. So for example, the idea of having a global commons problem, in this case, global environmental damage, and some kind of affirmative action, if you will, an equity-based affirmative action, if you will, of providing enabling support through finance and technology to developing countries, first had, I think, a clear conceptualization in 1972 with the Stockholm Declaration on Environment, which you can see here in some of its principles. Then it got reflected and I think made more explicit in 1992, as Elon was saying. Principle 7 says when you talk about the global environment, you have common but differentiated responsibilities in which developed countries acknowledge that they have that responsibility because of the pressure that societies have placed and then of technologies and financial resources that they command. And then Principle 7 then got reflected in the UN Framework Convention on Climate Change, where there's an explicit acknowledgement of that historical responsibility for greenhouse gas emissions, and that there is this acknowledgement that you do have to have this common obligation to work together, and then that then reflection in terms of its principles of the principle of common but differentiated responsibility, under which the developed countries would take the lead and then combat climate change and the adverse effects thereof. And how did the convention operationalize this? I prepared this schematic, and essentially what the idea there in the convention, then in climate convention, is that you have a set of common obligations accruing to all countries, both developed and developing, to undertake cooperation and mitigation, exchange information, cooperate on technology transfer, and all those things. But then you also have a set of differentiated responsibilities in which the developed countries, in addition to all of the things that they're supposed to do here together with developing countries, the developed countries would have a more robust set of obligations and responsibilities that they would have to undertake. And that would include, for example, quantified mitigation targets, provide finance, provide technology transfer, and when it comes to reporting, provide much more detailed information than is expected of developing countries. And the convention, climate convention was also is interesting because you do have an explicit paragraph in that convention that says that the extent to which developing countries would undertake would implement their commitments depends on the extent to which developed countries implemented their own commitments to provide finance and technology transfer to developing countries. And this framing, this narrative, this arrangement was reflected in the Paris Agreement that was adopted in 2015, where CBDR is explicitly referred to, and the same kind of approach was also then replicated in a way where you have common responsibilities or common obligations to, for example, provide 5-year nationally determined national action plans for climate change, to report altogether, to undertake collective reviews. But then you also had developed countries, again, having more explicit differentiated responsibilities in terms of financing and technology and reporting there. And so that's a climate regime. Elsewhere in the international environmental law, you also have reflections of CBDR. For example, in the Convention on Biological Diversity, you have a whole treaty with a huge number of provisions providing for common obligations for all countries, both developed and developing. But then you have a differentiated set of obligations for developed countries to provide technology transfer and to provide finance. And again, you see this link between what developed countries should be doing and what developing countries would be doing, that was in the Climate Convention also being replicated in the Convention on Biological Diversity. It's the same thing with respect to the Montreal Protocol and ozone depleting substances. Again, a common set of obligations for all countries, for all parties to it, and then a differentiated set of obligations for developing countries, for example, to be able to delay implementation, for developing countries to have access to technologies, and for developing countries needs to be taken into account. The same idea of having some kind of differentiated treatment for developing countries is also reflected in international trade law. So it's not just international environmental law that we're talking about, but it's also international trade law, where, for example, in the agreement to establish the World Trade Organization, you have explicitly in its preamble a recognition that when it comes to developing countries, their needs and their concerns have to be addressed, and there is a need for positive efforts, for affirmative action in a way, to help developing countries improve their economies. And then you see this in the WTO agreements, all the range of agreements that we have, where you have special and differential treatment provisions that will include increasing trade opportunities, safeguarding the interests of developing countries, flexibilities in implementation, transitional time periods, technical assistance, and other things. And so you have this range in virtually all of the major WTO agreements, approximately about 183, according to the WTO Secretariat, 183 special and differentiated treatment provisions in the WTO treaty regime. In international health law, I think what we have now is it's fairly new, yes, as Yolan was saying, but you do have a precedent already. For example, in the WHO Framework Convention on Tobacco Control, again, you have that same framing, that same architecture, if you will, that one saw in the CBD, and then you have CCC and in WTO agreements, where you have a set of common obligations with respect to tobacco control, but then you have a set of provisions that provided for some kind of differentiated treatment for developing countries. For example, Article 4.6 that talks about providing technical and financial assistance to tobacco growers and workers in developing countries. 22.2 in terms of cooperation, taking into account the needs of developing countries. 26.3 that would mandate parties to make use of different channels to provide funding to developing countries. And 26.5a to mobilize public and private finance and technical resources to assist developing countries. So when it comes to the pandemic treaty, what could we, for example, look at in terms of what possible elements could be undertaken? So obviously, in terms of the, I guess, treaty architecture, one would focus on having a set of common obligations. That set of common obligations could be around norms that would be developed. It could be about cooperation arrangements with respect to implementation or research or information exchange. It could be about transparency, like reporting, and could be about governance. But then the pandemic treaty could also come up with a differentiated approach section where one would have obligations for developed countries specific to them. For example, in terms of having creating an obligation on them to provide finance and technology and capacity building, technical assistance to developing countries. Maybe create a set of more detailed transparency reporting requirements for developed countries, and maybe making sure that they are going to be bound to implement their obligations as soon as the treaty enters into force. Whereas for developing countries, differentiated treatment could be in the form of providing them with longer time periods or transition periods, requiring all parties to take their needs into account, providing flexibility in terms of obligations or in terms of reporting. And then I think when we talk about the equity and its application to the pandemic treaty, it's really about making sure that the treaty system itself, the treaty regime itself, ensures that everybody gets what they need in order to be successfully implementing their obligations. It's the old Marxian quotation about from each according to the ability to each according to the needs. So that when we talk about the pandemic treaty, we will be able to hit 3 objectives. One is that the treaty will not be unduly burdensome on developing countries. Second, you are able to create a treaty that is linking and the enabling support that needs to be provided by developed countries to developing countries. 2, creating a framework of substantive equity and fairness and justice so as to encourage effective implementation. Because in the end, what we are hoping, or at least what I'm hoping we would achieve in the pandemic treaty, is to move from this reality, not do this, but achieve this, so that at the end of the day, when we have a pandemic treaty in place or normative changes to the IHR, we will arrive at some kind of a just framing of the treaty obligations there. And hopefully through that, we will be able to help address the global common concerns that the pandemic treaty is supposed to address. So let me end there. Thank you very much for listening.
Thanks so much, Vicente. We will come back during the discussions. Maybe you can expand a little more on what differentiated obligations specifically can look like in the pandemic treaty. We'll move over to Matyingai Sirleaf. Please, Professor Sirleaf, welcome.
Oh, thank you for that. And thank you for starting us off so nicely, Vicente. And so I hesitate to repeat anything that you've so eloquently laid out. And what I would like to do here is maybe just zoom out a little bit to talk about some of the principles or sort of normative underpinnings of thinking about common but differentiated responsibility. As my colleague just talked about, CBDR hints at requirements for states to coordinate the efforts in ways that effectively discharge their obligations to cooperate internationally, but also to achieve equity between richer countries in the global north and poorer states in the global south. Under it, richer countries take on higher obligations to combat things, as we just noted, like climate change or ozone depletion, to reflect the consumption and production patterns, as well as unequal distributions of risk of climate change and ozone depletion, which result in devastating consequences for everyone, but are felt even more so in the global south. And so thinking about what it would mean to progressively develop the principle of CBDR in global public health. And I love that you point out that sort of aspects of CBDR are already reflected in the Framework Convention for Tobacco, so to speak, is is a good jumping off point, because the first sort of element of common but differentiated responsibility is focusing on sort of shared obligations of two or more states in the environmental context towards an environmental resource. But there is no reason why this responsibility need only apply to environmental resources. The idea is that where resources are shared, like global public health, either because the resource is not sufficiently under the control of a state or under the sovereign control of a state, but it's subject to a common legal interest. So the idea is, what are things that are of common concern to humans or common heritage to humans, informing the principle of CBDR. And global public health and certainly the dealing with pandemic disease falls under something that's of common concern to all of us. And we have had the pandemic to sort of reiterate that or reinforce that. But also before then, I think states had began to recognize that when you're dealing with mutual risk, that people should be thinking about cooperating in a more of a spirit of global partnership. And so the second element of CBDR is probably the more controversial aspect, right? That there needs to be differentiated responsibilities, that there need to be burden sharing arrangements that are put in place. But there's no reason that differentiation should be limited to environmental law. The reasons why inequity are inbuilt in the international system are not limited to environmental law. So there are three sort of normative bases for thinking about differentiation. Of course, you can differentiate based on need, you can differentiate based on sort of culpability, and you can differentiate based on capacity. The differentiation based on need is probably the most straightforward, so I'll spend the least amount of time on that. We know that public health risks are distributed across all nations, but that some nations are more needful of assistance and are rendered especially vulnerable to pandemics disease. And so there's going to be greater need in some places than there are in other places. And having a CBDR approach takes that and puts a legal duty to sort of recognize and act upon that. And so one of the benefits of differentiating responsibility based on need is that it makes clear that the basis for obligations of international assistance and cooperation don't depend on anything sort of in addition to that. And so if we think about need-based claims for differentiation, there's probably less controversy on that. But the need-based claims sort of exist prior to the pandemic and exist sort of in spite of the pandemic, and the need-based claims sort of have not gotten us very far. And so there's also a need to differentiate based on culpability. And so thinking about expanding CBDR in the field of global public health affords a basis for differentiating based on an assessment of those who contributed to a harm and calls for apportionment of responsibility to address the harm in line with that determination. And so when you think about pandemics and epidemics and culpability, some might, raise their eyebrows because there's some contestation around this. But the idea is that rather than leaving states sort of solely responsible for addressing health inequities that exist in part because of the functioning of the international system, that we need to determine the role of historical, the role of history in sort of contributing to those inequities, and thinking about this not in sort of a narrow frame. So sort of what are the events that sort of immediately preceded the emergence of an epidemic disease or, the spread of a pandemic disease, but actually having a wider historical gaze to think about what are the factors in the international order that have made it such that countries are more vulnerable to epidemic diseases, for epidemic diseases to spread. And so we can think about the role of trade, investment, finance, intellectual property, the role of development, and the like, and how that has rendered health systems, some health systems more vulnerable than others. And we can think about the disproportionate distribution of those vulnerabilities and how that tends to be centered in the global South. And so this causal analysis, I think, is necessary for thinking about the structural causes of inequity that are inbuilt. So that image that my colleague just had up is helpful because on one breath, you could just focus on sort of capacity and just say, well, find capacity to do this. But if you don't look at history and if you don't look at structural inequity that's inbuilt, then it is as if we're running a race without sort of taking into account the reality of being able to respond effectively to epidemic and pandemic diseases. And so there's a need for thinking about how history has informed the current sort of fragility of health systems in the global South and the need for taking responsibility for that and implementing a CBDR approach to account for the ways in which the health sector in many places has been shrunk through the actions and requirements of, for example, international financial institutions. You can think about structural adjustment and its role in sort of limiting the health systems viability and ability to sort of respond in a robust manner to an epidemic or pandemic diseases. And that's just one example, but there are numerous other examples that you can think of in terms of the historical responsibility that has led to the deprivation of the right to health in a number of countries. And so thinking about this and the harmful effects of past actions are traceable to the limitations that countries have in being able to marshal an effective response to an epidemic or pandemic disease. And so this differentiation based on historical responsibility is something that is important. And again, this is an argument for corrective justice, right? So I saw one of the comments talking about referencing this, but this is an argument for corrective justice, and that one of the common arguments as well that actors today shouldn't be held responsible for things that were done in the past, but at the same time, history has to be owned and recognized. And so far as history can be traced to some sort of common lineage, then the bearers of that lineage have to face that. And historical responsibility could potentially deter actors from engaging in harmful action in the future, right? So if international laws contribute to this objective, then we have to create proper incentives and disincentives for actors such that they're not benefiting from in past injustices. And so we need to think about differentiating, not just based on need, but differentiating based on a recognition of historical responsibility. The other basis that underlines the CBDR approach is differentiation based on capacity. And differentiation of responsibilities based on capacity is also something that's fairly intuitive, right? So we should allocate responsibility to those who are best placed to do so. And that is irrespective of need or irrespective of historical responsibility. And so in an ideal world, this would be the state who's impacted by the outbreak. However, in reality, this in a number of situations, this is not actually the case. And so what do we do when there are vast discrepancies in terms of capacity to respond to a pandemic? And those who are most impacted or rendered most vulnerable may not have the capacity to respond forcefully to stop the spread of disease. And so one of the things that has been recognized in the climate crisis is that there is a need for capacity sharing and building partnerships, that there is a need to have policies like technical expertise that are shared and that further sort of the development in the global South such that countries are able to build their capacities to respond. And so you could think about capacity building in terms of research, information sharing, technical assistance, training and the provision of expertise, as well as financial and material assistance, especially where states lack the infrastructure necessary to address epidemic and pandemic diseases. So that's a non-exhaustive list of what factors might be considered in terms of thinking about capacity, but also thinking about how relative capacity compared to, so not sort of absolute capacity, but a relative capacity to act is going to be something that will matter. And so thinking about these three bases for differentiating based on capacity, differentiating based on culpability, and differentiating based on need are all embedded in the CBDR framework. And so thinking about implementing this in the global public health space would allow us to take into account the reality that exists. Instead, what we have is an attempt to have states respond irrespective of their capacity or irrespective of sort of historical functioning that has rendered health systems particularly vulnerable, or irrespective of need in the same way. And that does not sufficiently sort of take into account the world in which we are existing. And so CBDR, I think, if implemented, is a way to address global health challenges like pandemics, but also a way to take account of the history of global health inequities and trying to address those in a real way. So I'll stop there and then look forward to questions.
Thanks so much. Yes, we'll come back to questions. And my first question will be for you because you'll have to leave earlier than others. Burden sharing is quite a popular concept in Geneva, but it's also interesting to take note of obligations on capacity and need. We go over to Nirmalya, who will expand on some of the issues that you have touched on. Over to you, Nirmalya.
Thank you, Priti, and good afternoon to all of you colleagues. So first of all, taking off from the point that Vice was also referring to, the fact that CBDR, while it has been largely pronounced in environmental treaties, it's not a concept that is isolated in environmental agreements only. And you can find its reflection in other treaties. He pointed out to the FCTC and in a number of WTO agreements. But also beyond treaties, you could find exposition of the idea of CBDR that developed countries have an obligation to provide finance, technology, capacity building, not as a charity, but as an obligation towards developing countries, and a multiple of other international legal documents or documents expressing the will of states. For example, in the Declaration on the Charter of Economic Rights and Duties of States, the new International Economic Order, these declarations, which were adopted by unanimity in the UN General Assembly in the 60s and 70s, clearly espouse the obligations of developed countries to provide technological assistance, financial assistance across different sectors to developing countries, not as an act of charity, but as a legal obligation, something in the sense of reparative justice. And a particular reflection of this principle that was reflected in the new International Economic Order further on came into the WHO in the form of the Alma-Ata Declaration on primary healthcare, a declaration which sought to change the focus of WHO's work from focus on technocratic or technology-centric vertical interventions on specific diseases to looking at more systemic interventions on health, strengthening health systems in developing countries, an approach that led to the development or creation of programs such as the Essential Medicines Program and WHO's focus on to other issues, for example, intellectual property and access to medicines, which in the 80s felt a pushback, and we saw a re-emergence of vertical programs and also eking out of these vertical programs from out of the organization, leading to a further fragmentation of the WHO with what you have today in the form of a very fragmented global health order. So it is in that context that we need to look at this sense of historical responsibility that we have been talking about in the context of common but differentiated responsibilities. One of the questions I think that was placed before us was whether the principle of common but differentiated responsibility is a customary principle of international law. And if you want to look for evidence of this principle as a principle of customary principle of international law, you should be looking at, beyond treaties, these other international documents, UN declarations, etc., where you could glean out elements of common but differentiated responsibility. Interestingly, one of the sources of international law being opinions of distinguished legal scholars, I would refer to one particular article, 2004 article in the American Journal of International Law by C.D. Stone, titled Common but Differentiated Responsibility in International Law, where he contests the claim whether it has emerged as a principle of customary international law. But nevertheless, he admits in the very opening of his article that CBDR encompasses not only climate and ozone shield, but all risk-related global public goods, including, among others, public health. So perhaps that's a very clear exposition of the fact that CBDR is very relevant and applicable per se to public health. Keeping aside the question of whether it has, I would say that it has emerged as a customary principle of international law, but regardless of that, it is as a legal principle, it would still be applicable in public health contexts. Now, coming to the historical responsibilities, one of the issues that in the current discussions in the aftermath of the COVID-19 pandemic that has emerged, and I saw some references to historical responsibility issues in the chat as well, is that if you look at the international sanitary conventions from the 19th century to their current avatars in the form of the international health regulations, what you see is that the dominant focus in these international legal instruments relating to epidemic prevention and control is on containment strategy or quarantining, etc. When it comes to developing countries, you have very little, if at all, much focus on treatment focused interventions in developing country settings. And that again speaks to the issue of historical responsibility. I would end here with one particular quote from this book, Epidemic Illusions by Eugenie Richardson. And he writes that since the post-colonial period in West Africa, the dominant logic for epidemic disease containment, including smallpox, malaria, and influenza, has dictated isolation of sick individuals with little in the way of patient care. Thus, it was not surprising in my clinical work in 2014-2015 to find that many Ebola temples simply functioned to isolate sick patients while at most providing oral rehydration even to those with severe vomiting when they needed intravenous drips, and intravenous drips were available, but these were not supplied at the cost of containment strategy, because the focus was on health worker safety, the international health workforce that was going in over there. So that shows a distorted reality that we need to overcome through the insertion of the principle of common but differentiated responsibility, which, in my view, is at the heart of ensuring equity in the outcomes in the negotiations, both in the INB as well as in the revision of the IHR. Thank you.
Thanks so much, Nirmalya. We'll come back and talk more about the CBDR and the IHR during the discussion. Going over to Gopa. Gopa, are you ready?
Yeah, I think Professor Sirleaf is supposed to leave around after 1 hour, right? So
she'll stay on.
Probably people, if you want to ask some questions, yeah, okay. Then that's fine. So I will not take much time. So I just would like to stress 3 or 4 points. The point number 1, it is important to understand the current health emergency regime. How does it work? And as of now, the IHR creates an obligation to countries to inform, an international obligation to inform whenever there is an outbreak of disease happens and which has a potential of becoming a public health emergency of international concern. To have that capacity to inform, you are also has an obligation to maintain a core capability in terms of preparedness as well as response. But creating these obligations, IHR did pay some lip service saying that recognize the fact that there is a development divide existing, but nothing doing to address it effectively. As a result, what happens is that all the WHO member states, including especially the developing countries, where due to various reasons, these by and large the disease outbreak happens in the global south, and these countries has an obligation to inform. As soon as you inform, then WHO take its own course and the developed countries take its own measures. There is no guarantee, legal guarantee to return any help to address or contain this outbreak of disease. Of course, it does happen as a charity outside the IHR framework. Nothing is legally guaranteed. So in a way, IHR is being used to get an information. So far, you can take measures to protect your population. And first your population, then comes to do something beyond your territories. So this is a problematic approach. This is happening since beginning, as Nirmalya already mentioned, that since the sanitary conference and the focus of all these establishments of tropical and hygiene institutes in various colonial powers underlines the fact. So there is nothing qualitatively changed after that, and IHR legitimizes. And if you go through the IHR amendments proposals of the US, which reinforces, which even says that all the information shared by the member states to WHO should be shared immediately and quickly. So you get an information. So basically IHR is being used as a mechanism to send out information, and to get that information through a legitimate channel, and then you do your own things to protect your own population, but without any obligation to reciprocate, or without having any obligation to help those countries which are providing this information, because providing of this information also you are contributing to the international effort to contain this the outbreak of disease. So in simple one sentence, IHR basically is a mechanism to provide information from global south, and effectively I am saying provide an information from global south to north without creating any concrete legal obligation on the north to help out those countries who are facing this outbreak. So this status quo needs to change, but the proposals coming from US and others are reinforcing the status quo. So this here is the problem. And further, and my second point is that this is also part of their health security agenda. Health emergencies are viewed more as a health security issue with the involvement of militaries and national security agencies, and when involving bioweapon and other kinds of establishments. So this creates a what you call a trust deficit in the whole mechanism. The only way to address these changing the status quo and to create trust you should have some principles like CBDR. There is a legal guarantee that these are, it's a common problem. There is a mutual dependency, and therefore this needs to be addressed collectively based on principles of fairness, equity, and solidarity. But if you, from a public health perspective also, this is very important. It's a cliche now that everybody is not safe, nobody is safe until everybody is safe. But practically there is nothing people are doing to translate this concept into action. And in terms of when in the past, health emergencies also, though the products are getting developed in the north, but there are contributions because trials are happening in the south and people are contributing, including samples are sent mostly real time. So there is a basically I'm saying that there is a collective effort even in the product development, but the benefits are not being shared because it's all protected as intellectual property rights. So therefore, it is also important to have an ABS mechanism which ensures fair and equitable benefit sharing. So in other words, what I would like to convey is that it is not the technological capabilities of certain companies in the north is contributing to find out the products. There is a cooperation, there is a participation of people from the south or governments from the south in the whole mechanism. So the global health emergency mechanism involves, has the participation of everybody, but the benefits are not shared and on an equitable manner. Therefore, CBDR is a way forward to ensure a trust-based and mutually appreciative or mutually beneficial regime in the coming, to set up a regime in the coming days. So, having said this, let me now just discuss one point. The main objection in the last two IABs is that it's an environmental law principle. How can you apply in the health? But most of the health emergencies are going to emanate from the environmental degradation, loss of biodiversity, climate change. So next pandemic, there are publications now saying that next pandemic, the prime cause of next pandemic might be more or less it is coming from due to climate change rather than any other cause. So therefore, it is very much linked to the environmental degradation and cause of environment. So you cannot escape by saying that environment means something to do with something not to do with the health. So they are interlinked. So interlinked problems have the same principle can be applied, which is much more useful in the context of environmental law, also applicable here. Now the third point, and then I'll sort of would end here by saying that it is important to recognize this as a beginning or as a core principles, because otherwise, in the absence of non-recognition of this principle in the beginning, then it may affect the whole interpretation of the agreement. So therefore, it is important to agree as a principle, and then the question comes: which principle? Now, our discussion is by and large looking at the pandemic instrument, but I would argue that it is important to look at IHR also. Incorporation of CBDR is important in the IHR simply because of one reason: the public health emergencies of international concern will occur more rather than a pandemic. Pandemic may come. I'm not saying that pandemic may not occur, but the frequency, there is a difference. So while you are facing the current pandemic itself, we are undergoing two public health emergencies of international concern. So it is important, we need to recognize the CBDR within IHR. That will act as a building block or build resilience against the health emergencies. So otherwise you will have a very robust mechanism for a pandemic, which may come. It's like a waiting for a Gothe, but while people may die with this otherwise avoidable mortality. Okay, so this is the issue. So therefore, it is important to have this. And I will also call upon you to look at the Africa amendment proposals. They have certain proposals which has very much translate the concept of CBDR into action, or if they get adopted in the upcoming negotiations. So therefore, I would say that it is important to build the CBDR in both instruments, not only not only in pandemic, but also in IHR. So it's not the question of either or. Let me stop it here. Thank you.
Thanks so much. Thanks so much, Gopa. We'll come back to more specific questions for you. So we'll head straight to discussion. So what I'll do is I have one question for Matingai Sirleaf, and if anyone else has, please raise your hands and you can ask her a question, because she has to leave in about 10 minutes or so. So my question is, you spoke about need, culpability, and capacity as some of the factors for differentiation. And I think the most tricky one is going to be capacity. And you've said that in your literature that relative capacity as opposed to absolute capacity to act will be crucial in determining responsibility. Can you sort of expand on that? And I think while discussing this is going to be a key sticking factor on who agrees to pay up more and that kind of a thing.
Sorry, I was talking without unmuting, but no. So thank you for the question. Also, thank you for the provocations offered by the panelists on here. I'm really provoked and appreciate you all for organizing this dialogue. So I think that one of the things when you think about absolute capacity and relative capacity, it may be that a given place has absolute capacity, but their action might not be the preferred action given a number of other factors, maybe geopolitical considerations and the like, where someone with relative capacity that has more credibility or legitimacy to act in a given situation would be preferred. And so I think that there's a need to think not just about absolute, but also relative capacity. And so I say that because I think that there is a way in which we can think about sort of not increasing the burden sharing on countries in the global south, so to speak, but we might think about, if we think about sort of distribution of essential medicines or access to vaccines and the like. And so we might think of the relative capacity of countries like Brazil or India and the like, as opposed to sort of other countries, and thinking about ways in which that can be harnessed. And so that is what that is getting at. But I think it's important to sort of stress a couple of things that have come out in the conversation that I don't want to get lost. But part of why CBDR is so important to be included in the current reform efforts is that the extant principles that we have are not enough, right? The extant principles that we have us in this current predicament. The extant principles that we have us such that there is so much inequities when you think about even just vaccines and COVAX and that debacle, and the great divide that exists between countries in the global north and countries in the global south in terms of access to vaccines, where you see the hoarding of vaccines to vaccinate populations several times over, whereas some countries don't even have they're not even above 30% of their populations on the first dosage or anything like that. And so the current legal regime that we have is not enough to respond to the crisis that exists. And it is not enough to rely on international solidarity. It is not enough to say that you feel solidarity for those who are in a vulnerable position, right? Those principles that we have are not enough because they have not addressed thus far the reality of inequities in this space. And we need CBDR, as my colleagues have artfully articulated, because of the need to account for histories of subordination in global public health that go back all the way to the very founding of the global health regime, from the sanitary conventions, as was mentioned, which were premised on stopping the threat of diseases from colonized territories and colonized peoples and protecting the metropole. And so to the extent that we are trying to advance global health as a field beyond this sort of limiting the threat from the South and protecting the metropole, then we need to have principles like common but differentiated responsibility, such that we are taking account of this history of subordination in global public health that has prioritized the health of certain countries over others. And we need to correct, as my colleagues have mentioned, the pattern in global public health where it is about sort of notifying those in the north about a disease threat, and then essentially shutting off those areas once they've notified the rest of the world of an emerging threat of disease. And we can see that most instantly with South Africa's notification of the Omicron variant after its genomic sequencing and the consequences that South Africa, and not only South Africa, Southern African countries faced as a result of travel bans and the like. And so if we are going to disturb this pattern of sort of notification and then sort of punishing and ignoring countries, then we need to think about how to implement a CBDR regime to really just correct for not only historic, but sort of ongoing. I think that's important, right? So this is not just historic, but ongoing ways in which global public health has been subordinating, and to address for the effects of that continued legacy of that in global public health. Thank you.
Thanks a lot. I'm just checking if anyone else has a question for Professor Sirleaf, or we move on.
I think Priti Samantha Rick has her hand up.
Okay. Go ahead. Samantha, you have to unmute yourself.
Yes, it's like, Thomas, can you give Samantha permission to unmute, please? There we go.
Oh, there we go. Sorry. I thought the permission was the button. Following off of what Professor Sirleaf has just said, we know from the last year, there have been a lot of challenges in trying to get high-income countries and companies to adhere to what civil society wants in these respects. I was wondering if there's any lessons learned from getting these sorts of principles into other international agreements that you could share from advocates or experts of like who you talked to in each government that was like maybe reticent, and the arguments used to get them to agree. Thanks.
Thank you for that. I mean, I think that, so sort of the arguments for, which have been surfaced against sort of thinking about CBDR, it's like, oh, this is an environmental principle. There's nothing, as I said in my remarks, that makes CBDR something that is inherently sort of environmental. If we abstract the principle, which we can, there's nothing about it that we should limit it to thinking only about environmental resources. And yes, health and the environment are related. What we are talking about with respect to how to incorporate CBDR principle into the current reform efforts is not about, reducing emissions, right? We already have a regime that is aimed at reducing emissions. And so I think it's simplistic and a way to sort of just dismiss advocacy around including CBDR, because we're not looking to reproduce efforts, so to speak, that have already been long and hard fought in the environmental realm and simply sort of transplant them into global public health. But there are ways that you can abstract the principle of CBDR and think about what are ways that these principles, once abstracted, make sense in a public health context, in the global public health context. And that's what we're advocating for. And so I think what we have heard from ministers and others is a reluctance to, the international environmental versus international global public health. And I think another reticence is sort of, there is a sense that perhaps CBDR is laden with baggage from the environmental realm, not because it's environmental, but because there are problems with the way in which CBDR has been implemented in the environmental realm, that there might be concerns that those problems would be sort of mirrored if implemented in global public health. And I think that there's also, quite frankly, an instinct to not think about history, and that there is, and I think we need to ask who it benefits to not think about historical responsibility. Right, there are powerful actors who do not want us taking a longer gaze to thinking about responsibility for global public health inequities, and so that is something that is also informing the dis-ease, I think, with thinking about CBDR in this realm. And I hate to leave this very important conversation, but have other obligations that demand that I leave. But I look forward to continuing to be engaged with you all in this important work. Thank you so much for having me.
Thanks for joining. We will keep in touch. Just moving on to Vicente, I have this question, and we get to hear this from a lot of negotiators in Geneva about financing and implementation, and how we can borrow some of the successful lessons from climate negotiations on financing and implementation into the pandemic accord. And you also touched upon financing as a differentiated obligation. Maybe you can expand on how this will fit into the pandemic accord /IHR. Thanks.
Yes, thank you. Thank you for that, Priti. And it was really a great pleasure listening to Professor Sirleaf. I think let me contextualize my response to your question by linking it to the question that Samantha raised in terms of what were the lessons learned and how could we sort of like transpose that into the health field. One is that I think the key idea behind CBDR is, as I was saying, and I think as Nirmalya and Gopa and Professor Sirleaf were saying, is that you have this idea of equity, of fairness as being part and parcel of what we should be creating in terms of the global health regime. And that fairness, of course, implies that you have to look at historical responsibility, you need to look at need, how to address those needs, and then what would be the different kinds of institutional arrangements and legal arrangements that one could create in the context of making sure that that fairness is reflected. And I mean, in the climate regime, for example, and in the trade regime, I mean, generations of negotiators have sort of fought that fight. And it has always been a very much north-south fight because as you know, Professor Sirleaf was saying, our developed country negotiators tend to quickly develop historical amnesia. Forget about the past, we're looking towards the future. This is about all of us working together. And that will be the narrative, because they will say, you know, global problem, global commons issue, therefore global solutions. And what we have always been saying, I think as developing country governments, many of the developing country negotiators I've worked with over the past couple of decades, is that when you really drill down into what makes an environmental or a treaty work and be effective, it's about equity. Because equity is as one of my as my former boss Martin Corr was want to say, equity is the gateway to ambition. Equity is the gateway to implementation. It's when you have equity arrangements embedded in a treaty framework that then you can actually fairly say that the states, governments that are sort of like bound by the treaty would then have a fair idea of what they're supposed to do, and there would be some kind of fair burden sharing approach in the context of the treaty. So that's one. I think a lesson learned is in a context of inequalities, having a global treaty regime that does not reflect those inequalities and address those inequalities is bound to fail. So having a global treaty regime to address a global public health problem without equity arrangements in them will be a treaty regime that is designed to fail. Second, I think to get to that point where we are actually able to embed equity into a global health treaty regime, for example, those of us in civil society and those of us working with governments and governments themselves have to do a lot of organizing. And that is, I think, one of those lessons, again, learned from both the climate and the trade regimes. Developing country governments themselves have to take up the cudgels and push for that equity because no one else will fight for it on their behalf at the negotiating table. And that means organizing, organizing, and organizing, and networking with civil society advocates and governments working together. I was deeply engaged, for example, last year in negotiating this new fund called the Loss and Damage Fund in the climate negotiations. I was the coordinator for the Group of 77 in China at Sharm el-Sheikh, and before that in Glasgow, where we were trying to negotiate that, and we succeeded. And I think that was because of this good level of, high level of advocacy among civil society outside, and a very strong and united front of developing countries inside the negotiations, all working together. And we had many, I think, civil society comrades from the global north working in Washington, D.C., working in Brussels, putting pressure there as well, while we exert pressure from the negotiation. So that's, I think, the second lesson to be learned. And third, we have to be ready. If we want to get equity into a global treaty process on public health, we have to be very clear about exactly how do we want that to be reflected. It does not make sense to keep on talking about CBDR as a principle when we don't talk about how do we want it to be reflected. You know? And that was why in one of the slides I was showing that this is one way that we could reflect it. And one of the lessons, again, about 10, almost 15 years ago, I was engaged with developing countries in trying to help them think through this new, what you call, trade facilitation agreement in the WTO. And they were trying to struggle with the idea of, well, there's going to be a new treaty, which will impose new global obligations on all of us. And how do we then try to bring in equity ideas into it so that we would have some kind of flexibility? And so it wasn't, we ended up not focusing on putting in the phrase like special and differential treatment, but we focused on saying we need to have built into the arrangements of that new treaty itself things that reflect our idea of what fairness could mean, so that you would have either a linkage to enabling support or a linkage to flexibility provisions, and be very clear about how we want to craft that. And I think that is where our homework would have to be done. So those three things. One is, one is we have to be very clear about what we want. Second, we have to be very much organized and networked. And third, we have to focus on how we want to reflect that idea, rather than be stuck on just getting the phrase across, but really try to operationalize it. Thanks.
Thanks a lot. Nirmalya, maybe I can turn to you and, taking off from where Vicente left off. You said that, CBDR could technically be the heart of equity. And a lot of people will argue that equity does feature in a fairly prominent way in the conceptual zero draft. But how would you how would countries also ensure that CBDR is applied like a cross-sectional element throughout the text, for example, and maybe a procedural question on whether it's technically possible to actually bring this into the WHO. Thanks.
On the technical possibility of bringing CBDR into the WHO, as I mentioned, and as Vice Professor Sirleaf, Gopal, everybody also mentioned, CBDR as a concept cannot be something that is isolated only to multilateral environmental agreements. As I mentioned, in a way, without calling it as such CBDR, it has been reflected even in the WHO in the past, Alberta Declaration being a starting point. WHO is also increasingly getting, and as Gopa mentioned, we are in the discussions focusing on a One Health approach. We are looking and many of the future pandemic outbreaks could happen from those contexts. So in that way, there are logical anchorings through which you could sort of bring it into the WHO. Now, in terms of the reflection of CBDR in the conceptual zero draft or in the zero draft that would emanate, there is indeed scope for a greater reflection of the principle of CBDR, not just as a principle itself, but in translating it into action by inserting that into provisions that speak to equity. Currently, I would not completely agree with the fact that there are adequate provisions on equity in the conceptual zero draft. I think equity is being approached in a very limited sense in the conceptual zero draft as equitable access to medical countermeasures. And even within that conceptualization, there are significant restrictions and limitations. For example, the issue of intellectual property and how to deal with that. But equity is not and should not be limited to only access to medical countermeasures. Equity speaks to capacities of developing countries to undertake surveillance, build a strong and resilient health system, which would be able to prevent pandemic outbreaks, undertake surveillance in animal sector and in non-human health sectors so that zoonotic spillovers, etc., can be curtailed. And to also undertake, for example, genetic sequencing capacities themselves, right? Right now, the formulation as it stands, it's basically you give us, you share all the information, including the sequence information, and in return, probably as an act of charity or solidarity, you would get some equitable, quote unquote, access to medical countermeasures. That is not an adequate reflection of equity, and the way in which you could sort of translate CBDR into equity in that sense is to say what would be the exact obligations of developed countries when it comes to transferring medical countermeasures, when it comes to providing technology, finance, capacity building resources for building these health workforce or strengthening their health systems, etc. Essentially going back to a number of elements which are there in the Alberta Declaration in a way. Thank you.
Thanks a lot for that. Just one quick question to Gopa, and then I think Raymond wants to speak, and then we wrap up. Gopa, during the negotiations, discussions, we've also heard that there is a reluctance to talk about CBDR, but there's a lot of interest in discussing One Health. And I think Brazil, for instance, had pointed out that you can't talk about one without also talking about the other. Maybe you can touch upon that.
I think it's exactly what Nirmalya was trying to explain. The One Health is it is proposed and saying that it's kind of everybody's problem. We have to act collectively. Again, when you get into the details, always devil is in the details. So what they are trying to do, one main thing what they are trying to do is to create a huge infrastructure to gather data, including GSD, of not only human pathogens, but plant and animal. So that basically will facilitate a huge data flow from south to north without any corresponding obligation on how do we use this data, first. Second, what are the benefit sharing arrangement, whether there is any benefit will be ever be shared to give medical health products or those technologies. And most importantly, the first point, the purpose of using this data. Once you have this data, it can be used for many other purposes, right? Including achieving trade and economic objectives. So we don't have any kind of obligations, corresponding obligations are on the table for negotiations, but basically to commit countries to something called One Health without any clarity. So the only document which is available as of now is the joint work plan, which is not even a negotiated instrument, which has a very limited involvement of the member state. So
I think we don't hear
something which countries are being asked, or majority of the WHO member states are being asked to commit some.
We don't hear Gopa very well, so we are actually down to the last 3 or 4 minutes. But Nithin, do you want to intervene? And is Raymond still here? You can make your interventions quick. Thanks.
I'm still here. Can you hear me?
Yes, we can, Raymond.
Okay. Well, thanks a lot. I'd just like to come back to what Vicente said before, and I put it in the chat. I'll read it off briefly. Well, you suggested equity is the key, and that treaty regimes should include equity, which I agree with you. The question is just how to get there. What could be done for the developing countries and least developed countries to get this equity component into the treaties? Normally, as I would also say, and you know this from WTO, the negotiations are sort of based on making mutual concessions. If in the health sector now, what the Gupa just mentioned about data being provided by the South, going to the North and being potentially used for commercial purposes, and nothing gets back to the South. So what could be done in an international treaty setting if, bringing it up as a topic could only be sort of seen as moralizing, trying to get the North to make a concession, which they probably won't do, as they haven't done in the past, or just do a little bit. How could equity be actually really included? What are your thoughts about that?
Thanks for that, Raymond. That's an extremely good question. And I think it boils down, I guess, to also a political assessment of how much the North wants this treaty, for example. And how much are we, other developing countries, would be willing to put in place the sort of the kind of quid pro quo conditionality that one sees in the Climate Change Convention, for example, in Article 4.7, or in the Convention on Biological Diversity in Article 20, or in the WTO's Trade Facilitation Agreement in its Section 2, where essentially what the developing countries were able to extract is sort of like this relationship that, the extent to which they would implement their obligations under this new treaty would depend on the extent to which the developed countries would implement their own obligations to provide support to developing countries. And I think it has to be looked at in that context. Personally, I don't believe that equity should be a compromise point for developing countries. It has to be, I think, one of those red line issues, if you will, that they should be putting into the treaty. And this is the kind of strategy that that I think has worked in the past, particularly if developing countries are united. So that's what they could do. They really have to organize and see this as a key pivotal issue for them to be included in the treaty. Otherwise, you end up with a treaty that talks about One Health, which in the end becomes just health for the North. Thank you.
Thanks a lot. We'll have to conclude this session. It's been a great discussion and there's a lot to talk about. And quite progressive. I think we are coming out of this session with a lot of phrases to think about very seriously: affirmative action, corrective justice, and there is somewhat a recognition, at least in this community, about CBDR as recognized as customary international law, and also an opening perhaps to introduce CBDR in IHR amendments, as Gopa pointed out. And also I think the element of historical responsibility came through very clearly, from a number of speakers, which is interesting, but maybe difficult to negotiate. All right, I will hand over to Thomas, who has a number of announcements to make, and my apologies to others who wanted to intervene. Thanks so much. Thomas, over to you.
Yes, thanks. And thanks to everybody. Thanks to the panelists. Thanks to all of you who joined here. Also joining here silently for good reasons. Sometimes we invited member states to this discussion, and we know that quite a number of member state representatives have been with us for listening. And it's a bit a difficult moment to expose member states with making statements in a moment when we all expect a zero draft of the pandemic treaty to be presented by the Bureau of the Intergovernmental Negotiating Body. But we were here to share and to learn, and I learned a lot. So great thanks to all the panelists again, and to Preeti for moderating this session so nicely and greatly. We had a very intensive week of G2H2 policy debates, speaking on really different topics in intensive debates. And we are at the end of this week. And now it's a bit of time to digest, to maybe get back to the documentation, to listen to or watch the recording. This will all be possible from tomorrow on. So from tomorrow on, all the documentations and all the recordings will be online. So you can get there to do this follow-up, which is at least I need to watch some of the things we have done again. And next week we will be back daily with a morning session, which we call EB Today, which is a moment for civil society colleagues who attend the executive board meeting of the WHO to come together to look ahead to the day, what's on, what are the agenda items that need and deserve our attention, and to discuss also what we have heard and what we have share our assessments on what's on there in the meeting room of the executive board, to which civil society has only limited access. So that's next week, and for this week and for today we close, and with repeated thanks to everybody. Goodbye.